right now we are inviting Dr. Benjamin Chua, a medical director and a senior consultant vascular surgeon from Vascular and Interventional Centre. So welcome, Dr. Ben.
Hi, good afternoon. Thanks for joining us for talks on this series of pain management. My name is Benjamin Chua. I'm the medical director and consultant vascular surgeon at the Vascular and Interventional Centre. Today, I'm going to just share with you about a different aspect of pain, and that's specifically is in chronic pelvic pain in women. And this involves sometimes also the legs aside from the pelvis. So my title, my talk today is Addressing Chronic Pelvic Pain, Legs and Pelvic Vascular Pain. Now, the cause of pelvic pain in many women is generally due to this condition called venous reflux disease. What is venous reflux disease? It's characterized by a combination of the following. It's actually weak or incompetent vein valves resulting in leaks or backflow. And there's evidence of reverse flow in these veins. As a result, over time, these veins progressively enlarge and become engorged, resulting in venous blood pooling and affecting infected regions, causing clinical symptoms such as pain and heaviness. The pictorial on the right actually represents this. It shows you a healthy valve in which the healthy vein valves are unidirectional and keep blood flow generally moving in one direction, and that's back to the heart. When venous reflux disease is present, these valves are diseased, and as a result, blood now flows in two directions. And if you think about it, the pull of gravity causes a lot of the blood to then pool in dependent regions such as the pelvis or the legs, and causing elevated venous pressure. Now, the types of venous reflux disease can occur in different parts of the body and both in men and women. But for today, we'll focus on the two most common areas affecting women, and that will be lower limb varicose veins and pelvic congestion syndrome in women. How common is venous reflux disease? It is said that there's a worldwide prevalence, and it's estimated that 20% of the general population can have venous reflux disease, and it's the underlying cause of most varicose veins. In fact, it is more common than all the other types of arterial disease or blood vessel disease combined, such as coronary heart disease, peripheral artery disease, stroke, or congestive heart failure. So if you pull all that together, it's still not as prevalent as venous reflux disease. Now, specifically, I would like to talk about varicose veins. Now, what are they? They are basically swollen and twisted and large veins, mainly in the legs of affected patients. What happens is the valves in its veins are weakened, and it leads to backflow and pooling of blood in the legs. It happens in about 23% of the population, and it's actually more common among women than for men, about 67% of women. Who are at risk of varicose veins? Generally, the patients that see me fall into certain groups or types. There are people generally whose job requires them to stand for long periods of time, such as chefs, teachers, people in the retail industry. Women who have had 2 or more children are increased risk of developing varicose veins. And certainly people who have high BMI or obese, as you can think about it, because of their size, there's an elevated pressure on their veins, causing what we call a high ambulatory venous pressure, which then makes them at risk of developing varicose veins. How do we screen for varicose veins? Actually, the simplest is to use an ultrasound venous reflux scan using an ultrasound machine, and that's done quickly in the clinic. It is the gold standard. It's quick and affordable. It's not painful and not invasive. The picture on the right shows you exactly what type of scans we look for. It's actually very detailed, charting the pattern of the veins and the direction of flow. Obviously, in this patient shown here, he has severe venous reflux disease because you can see like the red arrows, they point back downwards instead of up. Up should be the normal flow pattern, but in this patient, pointing downwards suggests that there is some reflux or backflow. Sometimes we use an MRI and CT venogram, but this is only used if an ultrasound is too difficult to do. Now, what are the treatment options available? We break them into traditionally 3 groups: the non-surgical therapies, traditional open surgery, and minimally invasive treatment. Non-surgical therapies would be conservative therapy, and that involves either prescribing a patient compression stockings that has to be worn all times when the patient is up and about doing his activities. The only time we suggest not wearing the stockings would be at rest or at sleep. Then we suggest elevating the legs. That is a good way of treating, but it only provides control, but not long-term cure. Now, traditionally, the surgery has been open, which is a high tie and stripping of the veins. Also a good operation, but that can be painful. Nowadays, we go for minimally invasive treatment in which we make very tiny punctures in the veins to treat, and we use certain methods like a radiofrequency, we use glue or laser ablation, and that helps treat the veins and close it off without much pain and, in fact, very fast and quick recovery. Now, I'll go on into some of the therapies that we just mentioned. Compression stockings, and the compression stockings concept is to compress with external pressure onto a vein so that they do not backflow. So basically, you squeeze the vein shut. It needs to be worn daily, provides control, as I said, but not cure. The problem we find in Asia generally is the difficulty with use is the hot and humid climate. It's too tight and uncomfortable, and patients find it difficult to put on because they have to pull up the stockings and slowly. And this we find so in older patients or patients with arthritis. So as a result, compliance becomes an issue. Traditional open surgery, which is high tie and ligation, involves making a cut at the groin and passing a tube down the vein and removing the whole vein, or what we call stripping it. It is a very effective procedure, but it leaves big scars. It's painful, it needs general anesthesia, and a lot of my patients find that when you do this procedure, they take a longer time to recover, sometimes up to 2 weeks to a month before they get back to be normal. The new minimally invasive treatments is what most people do now and what we advocate, and that has significantly improved over the years, and it's done as a day surgery with no need to stay in hospital, and the results from the trials and the data have shown that it's equally effective as open surgery. My patients tell me they have minimal pain and discomfort. They're able to walk home after the procedure, and they can return to their sports activities in 3 to 4 days, and some return to work on the same day. On average, the pain score, they tell me, is about 1 to 2 out of 10 post-procedure without medication. More importantly, once we give them medication, they often don't feel very much in terms of pain. And most are returning to running and jogging 3 to 4 days, and some have gone on to marathons in about 1 week. The procedure is also very cosmetically pleasing with minimal scarring, and it's much faster in terms of recovery and no need to stay in hospital, making it more cost effective for the patient. Radiofrequency, this is a procedure in which a fiber or catheter, sometimes it's a laser fiber, sometimes it's a radiofrequency fiber, is inserted into the vein and is used to heat the vein from inside and then to close the vein. On the right, you see a different method where we use a venous seal or venous block, in which we put another catheter or tube and we use a medical grade glue to sort of plug and seal the vein. For both methods, the idea is to destroy the vein from the inside. For radiofrequency, basically we heat the wall up to 60 degrees and then it causes the vein to shrink, and eventually it will seal very nicely. For venous seal or venous block, the advantage is it doesn't use any heat, so there's no risk of thermal injury. And sometimes we don't even use compression stockings after the procedure. We usually do that for a period of 5 days if we use radiofrequency, but for glue, we don't need to do that. And essentially, some patients may find this usage of glue especially beneficial. Patients unsuitable for general anesthesia, and sometimes in very symptomatic pregnant patients, because we don't need any anesthesia, it's very safe. Now, there's still another group of patients who don't have main varicose veins, but have what we call spider reticular veins. These are commonly seen over the thigh and the calves, and they are what, as we can see here, green, thread-like, or sometimes purple or blue, and they occur in isolated patches over the thigh and the calves. Some patients may have underlying major superficial venous reflux disease, and some patients feel this congestion in these veins. So really, they feel heavy and painful when they sit for long periods of time as well. And this is just not purely cosmetic in nature, but really medical in nature. So for these patients, what we do is we do a procedure called CLACS, cryolaser and cryosclerotherapy, in which we use a transdermal laser to penetrate the skin, and we cool the skin to minus 20 degrees. And then finally, we follow through with an injection to cause these veins to seal or disappear. Again, this is a little bit different from the radiofrequency or the vena block I mentioned, because this is used to treat the smaller superficial veins. And it's useful in that it leaves behind minimal scarring and pigmentation. Now, we'll switch gears now and talk about pelvic congestion syndrome. And this is another cause of pain in women, and that's pain in the pelvis. All right, it's caused by varicose veins in the lower abdomen of pelvis, and so constantly results in a dull, aching pain in the pelvic area that may worsen at certain periods of time. And the weight of these enlarged veins can push against organs, causing constant pressure and pain. Usually develop in women 20 to 50 years old who have previously given birth or have a family history of the condition. What are some of the symptoms of pelvic congestion syndrome? And usually they complain of aching pain in the pelvis, and more so during menstruation. That's a condition called dysmenorrhea, or during intercourse, and that's dyspareunia, and sometimes even during urination. Some women experience frequent urination due to bladder irritability. They sometimes can get heaviness and swelling in the legs, as well as varicose veins or dilated veins around the vulva, buttocks, and the side of the legs down to the side of the calves. How do we diagnose this condition called pelvic congestion syndrome? Usually we do an ultrasound scan, pelvic ultrasound scan in women. Sometimes we do a laparoscopy. In fact, many of the patients who see me for this have had laparoscopy and colonoscopies done to exclude conditions in their bowel and small intestine. But for us, the gold standard, of course, is to do a CT, or what we call a CT-MR venogram, and that will show us exactly where the problem is. Now, the problem is actually a dilated, and as the picture shows, it's actually a dilated ovarian vein. The ovarian vein actually drains blood from around the womb and around the ovaries and brings blood back to the heart. But in this condition for pelvic congestion syndrome, the blood back flows downwards and causes congestion around the womb and around the ovaries. As a result, many women experience the symptoms as I discussed. So what are some of the treatment options available? Traditionally, the people have tried medicine, usually hormonal therapy or another drug called Deflon. This can sometimes alleviate some of the aching and pain, but does not cure it. Previously, it used to be open surgery where we ligate the refluxing ovarian veins, but that's very invasive and can be quite painful with slow recovery. I think the treatment option now that has become adopted worldwide and is recommended is something called percutaneous ovarian vein embolization. That's an endovascular procedure in which it is done like a day surgery through a puncture hole into the vein, and then what we do is we find our way to the ovarian vein, and then we close it off either by injecting some sclerosants, which are drugs to scar the vein, or we insert metallic coils to seal off the vein. This procedure is minimal in terms of causing pain and discomfort with a very quick recovery. And in fact, as we do it as a day surgery, many patients return to their daily activities quickly. So this procedure, ovarian vein embolization, is done under very light sedation and done as a day case. That's all I have to share about varicose veins and pelvic congestion syndrome, both of which cause pain for women, one in the legs and the other one in the pelvis. I'm happy to take questions now. Thank you.